Hello everyone, starting with chapter 8 of Illustrated Textbook of Pediatrics. Chapter 8, Child Protection. Features of child protection are protecting children from harm is duty of all health professionals. Physical and sexual abuse may dominate the media, but it also encompasses neglect, emotional abuse, sexual exploitation, fabricated illness, and female genital mutilation. Issues are often complex and difficult, so decision usually required a multidisciplinary approach by specially trained, experienced professionals. Children and young people require parents or carers who love, look after, provide shelter, and protect them from harm. Unfortunately, this is not the case for all children. Emotional, physical, and sexual abuse and neglect of children by parents, carers, and others continue to blight the lives of children and young people as it has throughout history. Recent issues in the protection of vulnerable children and adolescents have included harm from observing intimate partner violence, sexual exploitation, and female genital mutilation. Maltreatment significantly decreases the likelihood that a child will reach his or her full potential, although this is not inevitable. Some resilient individuals manage despite very adverse circumstances. Society, including the medical profession, was largely reluctant to accept that child maltreatment occurred until the second half of the 20th century, when attention was drawn by two American pediatricians to the battered child. It is now accepted that child abuse and neglect exist and legislation is in place making abuse a criminal offense. The UN Convention on the Rights of Child in the box shown specifically refers to the rights of children to be protected from maltreatment, both physical and mental. It gives governments the responsibility to ensure that children are properly cared for and protected from violence, exploitation, abuse, and neglect. In the UK, there has been a series of high profile cases of child abuse, starting with Maria Colwell in 1973 and followed by Victoria Climby in 2000 and Peter Connolly, Baby P, in 2007, resulting in the death of the abused child with multiple injuries. The prompted publication of reports and initiatives highlighting the need for better information sharing and cooperative working by health professionals. More recently, there was the tragic case of Daniel Pelka. The exposure of systematic sexual abuse of vulnerable young people, including abuse by a wide range of celebrity, political, and other high status figures over many years, has further highlighted the difficulties faced by all professionals responsibility for the welfare of children. Social workers, teachers, police, healthcare professionals, and those in many spheres of public life are more aware than ever of the need to recognize and respond appropriately to the alerting signs of child abuse and neglect. However, fear of missing child abuse has to be weighed against the damage of falsely accusing parents of abusing their child. This requires sensible judgment, excellent communication with the parents, and a professional culture in which any concern that child is being maltreated can be readily discussed with senior members of the team. High profile cases of child abuse can make some doctors frightened to deal with child protection or becoming overly suspicious from fear of missing cases, having led to improved multi-agencies guidelines and procedures have resulted in better, regularly updated child protection training for all health professionals. Now the picture, sorry. Now the box shown summary of United Nations Convention on the Rights of Child 1989. Number one is survival rights, the child's right to life and to the most basic needs, food, shelter, and access to health care. Number two is developmental rights to achieve their full potential, education, play, freedom of thought, conscience, and religion. Those with disabilities to receive special services. Number three is protection rights against all forms of abuse, neglect, exploitation, and discrimination. Number four, participation rights to take an active role in the communities and nations. Number box 8.2, a recent high profile case of child abuse in the UK. Daniel Pelka, aged 4 years, died from a head injury in March 2012. In the months before his death, he was denied food, force-fed salt, held underwater in a bath until become unconscious, and regularly beaten in prison in an unheated box room. Police received 26 reports of domestic abuse at his home. Lack of rigorous questioning and poor record keeping meant officials never got to the bottom of what was going on. The serious case review into his death identified three main failures when the abuse could have been stopped. Professionals believed his parents' story too readily in 2012 that he broke his arm when he fell off a sofa. His primary school failed to act on a pattern of injuries spotted during the 4 months before his death in 2012. Teachers watched him fish half-eaten food from bins because he was so hungry. His mother convinced them that he had an eating disorder. A pediatrician just a month before he died failed to spot child abuse as the key reason for Daniel's dramatic weight loss. He weighed less than 11 kg when he died. The report said professionals needed to have much more inquiring minds and to be focused and determined in their intention to address concerns that would have offered greater protection for Daniel. What is striking and depressing is that no professional ever asked Daniel how he was feeling, what was happening in his life that made him want to eat from bins. Talking to the child and seeking his or her view is a key component of good safeguarding practice. Now, the summary: child maltreatment existed for centuries, but societies have been very slow to acknowledge it as a problem. Children and young people are vulnerable and cannot protect themselves. The basis of children's rights. Protecting children and young people from harm is a key role of parents or carers and all involved with children. All healthcare professionals, social workers, teachers, police, and others have a duty to ensure that they know what to do if they have concerns that a child or young person may be being abused. Now, types of child abuse and neglect. Abuse and neglect are both forms of maltreatment of a child. Somebody may abuse or neglect a child by inflicting harm or by failing to act to prevent harm. Children may be abused in a family, at home, or in an institution or community, usually by someone known to them or more rarely by a stranger. They may be abused by one or more adults or another child or children. Conventionally, child abuse is characterized into physical abuse, emotional abuse, sexual abuse, including sexual exploitation, neglect, fabricated or induced illness. In addition to these categories, witnessing intimate partner violence is regarded as a form of child maltreatment. In the UK, the practice of FGM is also regarded as a form of child abuse. Physical abuse may involve hitting, shaking, throwing, poisoning, burning or scalding, drowning, suffocating, or otherwise causing physical harm to a child. Emotional abuse is the persistent emotional maltreatment of a child, resulting in severe and persistent adverse effects on the child emotional development. It may involve conveying to children that they are worthless or unloved, inadequate, or valued only insofar as they meet the needs of another person. It may feature developmentally inappropriate expectations being imposed on children. These may include interactions that are beyond the child's developmental capabilities, as well as overprotection and abnormal social interaction. It may involve seeing or hearing the ill treatment of another child or person. It may also involve serial bullying that causes children to feel frightened or in danger, or the exploitation or corruption of children. Some level of emotional abuse is involved in all types of maltreatment of a child, although it may occur alone. Sexual abuse and sexual exploitation. Sexual abuse involves forcing or enticing a child or young person to take part in sexual activities, including prostitution, whether or not the child is aware of what is happening. The activities may involve physical contact, including penetrative acts such as rape, buggery, or oral sex, and or non-contact activities such as involving children in looking at or producing pornographic material or watching sexual activities or encouraging children to behave in sexually inappropriate ways. Sexual exploitation is a type of sexual abuse in which children are sexually exploited for money, power, or status. Children or young people may be tricked into believing they are in a loving, consensual relationship. They might be invited to parties and given alcohol and drugs. They may also be groomed online. Some children and young people are trafficked into or within the UK for the purpose of sexual exploitation. Sexual exploitation can also happen to young people in gangs. Is a persistent failure to meet a child's basic physical and or psychological needs, likely to result in the serious impairment of the child's health or development. It may involve a parent or carer failing to provide adequate food and clothing, shelter, including exclusion from home or abandonment, protection from physical and emotional harm or danger, adequate supervision, including the use of inadequate caregivers, access to appropriate medical care or treatment. It may also include neglect or unresponsiveness to a child's basic emotional needs. Fabricated or induced illness. This is a broad term to describe a group of behaviors by parents or carers, but usually the mother more than 80%, which cause harm to children. It fulfills the parents or carers' own need. It may consist of verbal fabricated. Parents fabricate, i.e., invent symptoms and signs in the child, telling a false story to healthcare professional, leading them to believe the child is ill and requires investigation and treatment. Medical and nursing staff are used as an instrument to harm the child through unnecessary interventions, including medication, hospital stays, intrusive tests, and surgeries in community settings. The false stories may lead to medication, special diets, and restricted lifestyle or special schools. Special schools, and then induction of illness may involve suffocation of a child, which may present as an acute life-threatening event, administration of noxious substances or poisons, excessive or unnecessary administration of ordinary substances, for example, excess salt, excess or unnecessary use of medication prescribed for the child or others, the use of medically provided portals of entry such as gastrostomy buttons, central nines. Organic illness may coexist with fabricated or induced illness in a child, thus making the fabrication more difficult to identify. It may manifest as overprotection, imposing unwarranted restrictions, or giving treatment that is inappropriate or excessive. The condition can be extremely difficult to diagnose but may be suspected the child has frequent unexplained illnesses and multiple hospital admissions with symptoms that only occur in the carer's presence and are only substantiated by clinical findings. This disorder can be very damaging to the child, as unnecessary investigations, potentially harmful treatment are likely to be given. The child also learns to live with a pattern of illness rather than ill health. In induced poisoning, the diagnosis may be made by identifying the drug in the blood or urine. Intimate partner violence. Observing violence between adults who are or have been intimate partners or family members, irrespective of sex or sexuality, is also a form of abuse. Threatening behavior, violence, and abuse, psychological, physical, sexual, financial, or emotional, recognized to contribute to poor short term and long term outcome for children and young people. Female genital mutilation. This is defined by the WHO's as all procedures that involve partial or total removal of external female genitalia or other injury to the female genital organs for non-medical reasons. It is recognized as a violation of human rights of women and girls. Between 100 to 140 million women and girls are thought to be living with the consequence of female genital mutilation. It is nearly always carried out on minors. In December 2012, the United Nations General Assembly unanimously voted for its elimination throughout the world. In the UK, child protection procedures are followed when there are concerns that a girl is likely to be subjected to or has undergone female genital mutilation. Prevalence of child maltreatment. It is only possible to estimate the size of the problem in high income countries where there are official statistics from agency investigating victims, for example child protection services or the police investigating victims and offenders. According to the National Society for Prevention of Cruelty to Children in England in 2013 and 14, there were over 11.5 million children under 18 years. Almost 400,000 children receive support for children's services. About 3.5% total child population, over 48,000 children were identified as needing protection from abuse. About 4.4% of total child population, over 62,000 children and young people talk to Childline about abuse. There are over 68,000 children in care. They estimated that for every child identified as needing protection from abuse, another 8 are suffering abuse. Studies based on self-reports, as shown in Table 8.1, from victims who are old enough to comply with surveys, or studies based on parents reporting severe physical punishment or patterns of care tend to confirm this. Discrepancy between official agency data and those from self-reports underlines the fact that only a few children who are maltreated receive official attention. Furthermore, evidence from several studies suggests that children who are exposed to one type of maltreatment are at risk of other types and of repeated exposure over time, and that the frequency of exposure is correlated with the severity of maltreatment. For a few children, maltreatment is a chronic condition, not an event. Health professionals have a key role in helping children avoid the devastatingly damaging effect of maltreatment and need to be alert to the possibility that the child is in front of them or the children of the adult is in front of them may be being maltreated. Now we will discuss the picture that is shown. Female mutilation, WHO types 1, 2, 3. Normal is shown, and then type 1 is shown. Purpose removal only, or purpose removal and partial or total removal of clitoris. And type 2 is removal of the clitoris plus part of all of labia minora. And type 3 is removal of part of or all of the labia minora, with the labia majora sewn together, covering the urethra and vagina and leaving a small hole for urine and menstrual fluid. Female genital mutilation. And this table 8.1, cumulative prevalence of abuse from self-report 0 to 18 years in high income countries. Types of abuse, cumulative prevalence: physical is 5 to 35%, sexual all forms 15 to 30% for girls, 15 to 15% for boys, emotional is 4 to 9%, neglect is 6 to 12%, witnessing intimate partner violence is 8 to 25%. Now, safeguarding children. Safeguarding is a term used in child protection processes and procedures in the UK. It means that not only should we intervene when there are clear instances of child maltreatment as set out previously, but also vulnerabilities should be recognized and alerted to those involved in looking after the child or young person. This includes the parents or carers, teachers, social workers, and the police. Providing early help is more effective in promoting the welfare of children than reacting later. The key principles of safeguarding children are: safeguarding is everyone's responsibility. For services to be effective, each professional and organization should play their full part. Child-centered approach. For services to be effective, they should be based on a clear understanding of the needs and views of children. Safeguarding is everyone's responsibility. Respected. Child maltreatment occurs across socioeconomic, religious, cultural, racial, and ethnic groups. Although no specific causes have been definitively identified that led a parent or other caregiver to abuse or neglect a child, research has recognized a number of risk factors commonly associated with maltreatment. Children within families and environments in which these factors exist have a higher probability of experiencing maltreatment. It must be emphasized, however, that although certain factors are often present among families where maltreatment occurs, this does not mean that the presence of these factors will always result in child abuse and neglect. For example, there is a relationship between poverty and maltreatment, yet most people living in poverty do not harm their children. Presentation: child abuse and neglect. Child abuse may present with one or more of physical symptoms and signs, psychological symptoms and signs, and a concerning interaction observed between the child and the parent or carer. The child may tell someone about the abuse. The abuse may be observed. Identification of child abuse in children with disabilities may be more difficult. Disability is also a risk factor for child abuse. In order to diagnose child abuse or neglect, a detailed history and thorough examination are crucial. In most instances where child abuse is considered, seeking advice from colleagues, for example, more experienced members of the team, pediatric radiologists and pediatric or orthopedics surgeons, is essential. Factors to consider in the presentation of a physical injury are the child's age and stage of development, the history given by the child, if they can communicate, the plausibility and or reasonableness of the explanation for the injury, any background, for example, previous child protection concerns, multiple attendance to accident emergency department or general practitioner, delay in reporting the injury, inconsistent history for caregivers, inappropriate reaction of parents and caregivers who are vague, evasive, unconcerned, and excessively distressed or aggressive. It is often not clear whether an injury is inflicted or non-inflicted. Gives example. The next table will give examples of injuries and a guide as to the likelihood that it is due to an inflicted injury. The context and observations of family are very important in evaluating injuries that may be inflicted. The box 8.3 show the risk factors for child abuse in the child: failure to meet parental expectations and aspirations, for example, disabled, wrong gender, difficult child, born after forced, coercive, or commercial sex, parent or carer, mental health problems, parental indifferences, intolerance and over anxiousness, alcohol, drug abuse in the family, step parents, domestic violence, multiple closely spaced births, social isolation or lack of social support, young parental age, environment, poverty and poor housing. Physical injuries that can be caused by child abuse. This shows a case history. Now the case history, that is 8.1, severe child abuse. 2-month-old boy was brought to the accident emergency department by ambulance with sudden loss of consciousness. His mother, accompanying him, appeared to have learning difficulties and could not explain what had happened. His father arrived soon after and said that he had been changing the child's nappy on the floor, and when suddenly he went all floppy and asleep. The child was unresponsive, U on AVPU, and had shallow breathing. His pupils were dilated. He appeared well nourished and well dressed, only in a nappy, and was dressed only in the nappy. There were no obvious injuries seen. Medical management was rapidly instituted. CT head scan showed subdural hemorrhages. Chest X-ray obtained following intubation showed old posterior rib fractures. Subsequent ophthalmological examination showed bilateral retinal hemorrhages. The child was transferred to intensive care unit where he died. A postmortem skeletal survey showed metaphyseal fractures. The parents maintained the story despite the compelling evidence of inflicted hand injury and shaking. The case went to the criminal court and both were sentenced on a number of charges. Severe physical abuse resulting in death gains considerable attention from the media but is rare. Many more children suffer permanent injury. Most have been seen previously by health professionals. Early recognition and response to child protection concern could prevent severe injury. Fracture lines with no healing in the X-ray. Multiple rib fractures of different ages are shown. Multiple rib fractures retinal hemorrhages from trauma of the head, and metaphyseal fracture of distal humerus, subdural hematoma, acute blood loss in subdural space. Now, examples of injuries and a guide to how likely it is due to an inflicted injury. Injury: fractures most likely to be inflicted. Any fracture in a non-mobile child, excluding fragile bones, rib fractures, multiple fractures, unless significant accident trauma, for example, rotator fracture, multiple fractures of different ages, may be inflicted. Accidental underlying disorder: skull fracture in young child, long bone fractures in young but mobile child, less likely or unlikely to be inflicted. Fracture in school age child with witness trauma, fall from swing. Bruises most likely to be inflicted, as in bruises in the shape of a hand or object, bruises on the neck that look like attempted strangulation, bruises around the wrist or ankles that look like ligature marks, bruise to the buttocks in a child less than 2 years or any age without a good explanation. Bruising to the trunk with a vague history may be inflicted. Accidental or underlying disorder, less likely an underlying disorder or unlikely to be less likely to be inflicted. Bruises on the shins of a mobile child. And the third one is burns. Any burn in a child who is not mobile, a burn in the shape of an implement, cigarette iron, a glove, a stocking burn consistent with forced immersion, and less likely cause of inflicted is burn to mobile toddler with splash marks, history of pulling drink onto himself, but may indicate neglect in the form of poor supervision. Bites: bruising in the shape of bite, thought unlikely to have been caused by a young child, and highly unlikely if that is not an inflicted wound witnessed biting of one toddler by another. Picture showing bruising from finger trauma to a baby's head. Scald with stocking distribution, including the soles from forced immersion in hot water, and a bite mark on an infant's leg. Adult bite marks may be seen in abuse, but bites from other children are not uncommon. Key features of bruising: the age of the bruise cannot be accurately estimated. Bruising is hard to detect on children with dark skin. Mongolian spots can be mistaken for abuses, as they may still be present at several years of age. Neglect: consider the possibility of neglect when the child consistently misses important medical appointments, lacks needed medical or dental care or immunization, seems ravenously hungry, is dirty, is wearing inadequate clothing in cold weather, is abusing alcohol or other drugs, says there is no one at home to provide care. Consider the possibility of neglect when the parent or other adult caregiver appears to be indifferent to the child, seems apathetic or depressed, behaves irrationally or in a bizarre manner, is abusing alcohol or other drugs. Emotional abuse: this damaging form of abuse can be difficult to identify in a single brief healthcare interaction with the child and carer. Case history will be discussed later, but may be apparent when the observation period recurs or is longer, for example, in an inpatient or neonatal unit setting. Some clues may be found by noting how the parent or caregiver perceives the child. Is the child the wrong gender, born at a time of parental separation or violence, seen as unduly difficult? There may be clues from the behavior of the child. This depends on the child's age. Baby is apathetic, delayed development, non-demanding, described by the mother as spoiled, attention seeking, in control, not loving her. Toddlers and preschool children: violent, apathetic, fearful. School children: vetting, soiling, relationship difficulties, non-attendance, antisocial behavior. Adolescent: self-harm, depression, oppositional, aggressive, and delinquent behavior. In addition to emotional abuse by a parent or carer, bullying by other children is increasingly recognized as an important form of emotional abuse. Every school should have a written bullying policy that needs to be implemented when necessary. Sexual abuse is suspected. Sexual abuse information from different sources needs to be pieced together. Recognition: the child or young person may tell someone about the abuse, be identified. in pornographic material be pregnant by legal definition. This is due to sexual abuse for a girl under the age of 13, have a sexually transmitted infection with no clear explanation, but some sexually transmitted infections can be passed from the mother to the baby during pregnancy or birth. Physical symptoms: vaginal bleeding, itching, discharge, rectal bleeding. Behavioral symptoms: any of the symptoms outlined for emotional abuse in the previous section. Unexpected awareness or acting out of sexualized behavior beyond what would be expected for age. Soiling, secondary enuresis, self-harm, aggressive or sexualized behavior, regression, poor school performance. Signs: there are few definitive diagnostic signs of sexual abuse on examination, and nearly all examination after suspected sexual abuse show no positive findings. This is because sexual abuse of children often comprises touching or kissing or other activities that do not involve significant physical force. Furthermore, the genital area heals very quickly in young children, so signs may be absent even a few days after significant trauma. Forensic material also decays rapidly. Examination of children suspected of having been sexually abused requires a doctor with specific expertise and training. Facilities for photographic documentation, sexually transmitted infections, infection screening and management, and where indicated, forensic testing. As shown on the figure, forensic testing of swabs from the child or his or her clothing, bedding may reveal DNA from body fluid of the perpetrator. Investigation: physical abuse, fracture in young children may not be detectable clinically, and x-rays are required to identify them. Bruising over line of fracture is rarely seen on presentation. A full radiographic skeletal survey with oblique views of the ribs should be performed in all children with suspected physical abuse under 30 months of age. Some lesion may be inconspicuous initially, but if indicated, becomes evident on a repeat x-ray 1 to 2 weeks later. Other medical conditions that need to be considered and excluded in suspected child abuse are bruising, coagulation disorders, Mongolian blue spots on the back or thighs, fractures, osteogenesis imperfecta, common referred to as brittle bone disease type, commonly involved with unexplained fractures in type 1, which is an autosomal dominant disorder, so there may be a family history. Blue sclera are a key clinical finding, and there may be generalized osteoporosis and bone bones in the skull, extra bones within skull sutures on skeletal survey. Scars and cigarette burns may be misinterpreted in children with bullous impetigo or scalded skin syndrome. Where brain injury is suspected, all children require an immediate CT head scan followed later by MRI head scan, a skeletal survey to exclude fractures, and expert ophthalmological examination to identify retinal hemorrhages, a coagulation screen. Management: abused children may present to doctor in the hospital or medical nursing staff in the community. They may also be brought for a medical opinion by social services or the police. In all cases, the procedure of the local safeguarding children board should be followed. For children who are able to talk, it is good practice to use a chaperone and speak to children without parents present. The medical consultation should be the same as for any medical condition with a detailed history and full examination. It is usually most productive when this is conducted in a sensitive and concerned way without being accusatory or condemning. Any injuries or medical findings should be carefully noted, measured, recorded, and drawn on a body map and photographs with consent. The height, weight, and head circumference where appropriate should be recorded and plotted on a centile chart. The interaction between the child and parents should be noted. All notes must be meticulous, dated, timed, and signed on each page. Treatment of specific injury should be instigated and blood tests and x-rays undertaken. If abuse is suspected or confirmed, a decision needs to be made as to whether the child needs immediate protection from further harm. If this is the case, this may be achieved by admission to the hospital, which also allows investigation and multidisciplinary assessment. If sympathetically handled, most parents are willing to accept medical advice for hospital admissions. For observation and investigation, occasionally this is not possible and legal enforcement is required. If medical treatment is not necessary but it is felt to be unsafe for the child to return home, A placement may be found with foster carers. When dealing with any child suspected of having been abused, the safety of any other sibling children at home must be considered. The police and or social services should be alerted to any concerns. In addition to a detailed medical assessment, evaluation by social workers and other health professions will be required. A strategy meeting and later a child protection conference may be convened in accordance with local procedures. Members may include social workers, health visitors, police, general practitioner, pediatrician, teachers, and lawyers. Parents attend all or part of the case conference. Details of the incident leading to the conference and the family background will be discussed. Good communication and trusting working relationship between professionals are vital, as it can be extremely difficult to evaluate the likelihood that injuries were inflicted deliberately and the possible outcome of legal proceedings. The conference will decide whether the child should be provided with a child protection plan and under what category. See the next case, whether there should be an application to the court to protect the child, what follow-up is needed, why is child protection so difficult. Child protection goes against the assumption that parents usually have their children's best interest in heart, can involve confronting parents who may be manipulative or aggressive, requires detailed evaluation of the history and examination to identify inconsistencies and interpret subtle findings, depends on generally good multi-professional teamwork and respect of colleagues. Now the case histories, and now the first case history is their emotional abuse or neglect. A general practitioner sees a 60-year-old boy for recurrent abdominal pain resulting in missing 20% of school this year. The boy and his mother are accompanied by his 3-month-old sister. The boy is all over the clinic room, climbing onto the examination couch, turning the ophthalmoscope on and off, crawling under the desk, trying to get hold of the computer keyboard and running the tap water of the hand basin on and off. The baby is crying, but her mother is holding her at arm's length and not comforting her and taking any notice of her son's behavior. With the help of a clinic nurse, the boy is shown some toys and settles down and shows some good ability to put a simple jigsaw puzzle together. The baby keeps crying until the mother eventually gives her a bottle of formula from her bag. The mother's affect is very flat and is vague about the history of abdominal pain and why so much school has been missed. Examination shows that he is on the 50th centile for height and weight. His mother says that she has lost his personal child health record. He's in school uniform and is clean, but his hair is not brushed. He has dental caries, but mother cannot remember when he last saw the dentist. The boy says that he cleans his teeth twice a day. He has some bruising to the shins, but examination is otherwise normal. From this description, what are the concerning features? What are the positive features? Which will be discussed in the next table. What else do you need to know? Who else is at home? Partner, other children, others. What other support is available? Family, friends, mother's own health and health of others in the household, social work involvement previously. Who else would be helpful to involve in order to address the concerns raised? The main concern is about mother's flat affect. Does she have significant mental health problems that are impairing her ability to be what the child psychiatric Donald Winnicott called a good enough parent? The general practice health visitor and school nurse would have additional information. Children's social services need to be contacted to see if the family is known to them. Is the child known to other hospitals or professionals? Meeting could enable all those involved with the family to obtain a more complete picture and plan appropriate support and monitoring. This case history demonstrates concerns about any form of abuse. Is this instant possible emotional abuse and neglect may arise in a number of settings. Once possible concerns arise, the clinician needs to know what to do next. Arranging a meeting of information sharing to obtain a detailed picture is a helpful first step. Early intervention and appropriate support to families may prevent more severe harm. Now the table is showing the concerning and positive features relating to family. Concerning features are the 6-year-old boy has missed 20% of school, very active, risky or inappropriate behavior in clinic. Does he have attention deficit, hyperactivity disorder? Hair is not brushed, has dental caries, baby crying most of the time. Mother effect seems very flat, not willing to stop inappropriate behavior, holding her baby at arm's length and not comforting her. Cannot remember when her son last saw the dentist, has lost the personal child health record. Positive features: 6-year-old shows good concentration, is in school uniform and is clean, says that he cleans his teeth twice a day, growth is satisfactory. Mother has thought to bring along a bottle of formula for the child, has dressed the 6-year-old in a clean uniform. Next figure shows the assessment of sexual abuse like a jigsaw puzzle. Many different pieces of information need to be pieced together to make an informed opinion. History from parent, child history, any disclosure, physical symptoms, behavior, bruises, physical examination, sexually transmitted diseases, forensics, police inquiry, social work, and assessment. The next pictures of a thorough medical assessment is required in all children when non-accidental injury suspected. This kind of large bruise followed what was said to be a minor bump. Non-accidental injury was suspected, but examination showed multiple bruises in petechiae. She had immune thrombocytopenic purpura. The next injury case history: 8.3 possible child abuse. Parents brought their 8-month-old daughter into the children emergency department. They were worried that she had not been moving the right arm for that day. The family remembered at the evening meal 2 evenings before, her father was bringing dishes for the family meal to a low corner coffee table in the sitting room. Mother was sitting with baby on a knee next to a table trying to control the older siblings. When father had accidentally dropped a heavy serving bowl of food, mother automatically reached out to try to catch her, dropping the baby in doing so, and in the confusion the serving bowl hit the baby's arm. The baby cried very loudly for about 10 minutes or so, but then seemed to settle. Next day she did not use the right arm, but the family thought this was explained by injury causing a strain, as they could not see any bruising on the arm. An X-ray showed a fracture of the right radius and ulna. Child protection concern: baby under 1 year with fracture, delayed presentation. Positive features: plausible, consistent story, good parent-child interaction observed by medical and nursing staff, well nourished, well cared for parents of baby, no other injuries on full examination. Skeletal survey showed no other fractures. Personal child health record showed regularly weighed, thriving baby up to date with immunization. No general practitioner or home visit concerns about the family. Not previously known to local children's social services. Outcome strategy meeting: no additional concerns identified. Decision: increased health visitor contact and parents received advice about safety in the home. In child protection, conclusive evidence is often not available. Now, the summary: child abuse is the responsibility of all doctors and must not be avoided or ignored because it raises difficult issues and possible appearance in court. It takes various forms: physical abuse, emotional abuse, sexual abuse, neglect, and fabricated or induced illness. The interests of the child should be kept uppermost to ensure protection from harm. In many instances, it is uncertain whether or not the problem is one of child abuse. Good communication with the parents and child is vital. This is the end of the chapter. Thank you.